So we are officially recording. We have gone through this poem document a little bit earlier in the year during the didactics. So this is kind of one that we prioritized for this short period of time because we can go through it a little bit quicker and really pay attention to very commonly tested themes and topics to kind of choose to repeat those again. I'm actually going to skip the PFT page. I'm going to send out a link to a video that Lacey did. That was an excellent review of PFTs, and I think is going to be a great, maybe 15, 20-minute refresher to look at in the couple of weeks kind of leading up to the test. So we're going to be starting with obstructive lung diseases, asthma and COPD. All right, everybody's on page 2. So in terms of asthma, they are going to want you to really pay attention to the step-up therapy, right? And the one that they commonly test that I would have you circle is this step right here. So somebody who is just on a short-acting bronchodilator and still having now mild persistent symptoms, right? They are going to be wanting you to start inhaled corticosteroids as the next preferred step in management, right? So this step here is different than our next step with COPD when we're moving somebody from just albuterol PRN. COPD is not really an airway inflammation, so we are not going to be giving monotherapy with inhaled corticosteroids. Also, there's a lot of data for patients with asthma demonstrating really increased mortality and risks with doing long-acting bronchodilator therapy, right? So you always need to think of it as the reverse, and because it's the reverse and really it's a never event of something that you should be doing, they will test about it on every single exam. So in terms of this ladder here, you have your symptom categories, you have kind of your FEV1 and FVC ratio changes. I would say the more important one to memorize is going to be the symptoms. And I usually remember mild persistent because it's more than 2 days per week and it's more than 2 nights per month, right? So it's the 2s, and that will kind of give you, if it's not that, it's intermittent, and if it's more than that, it's moderate persistent. So that's kind of the one that I always stick in my brain. So as you're going up this ladder, right, so you're on a short-acting albuterol as needed, you add on a low-dose inhaled corticosteroid. Your next step is increasing your corticosteroid or now adding on the long-acting beta agonist. I think a couple of questions could ask for more refractory patients, what additional therapies could you use? And so that is question number 1 on this side sheet. Right, so medications that can be used in severe allergic refractory asthma. So if somebody has also a high IgE level, omalizumab.
Yeah, is there usually a cutoff that they say like when you can use it?
So for the IgE level?
Yeah.
I believe 30. So it's still kind of upper limit of normal. And on the test, they'll give you the reference range for the IgE level with it. But I don't think they would make it borderline like that. They would give you somebody who has.
Because I know like there's been questions where they give you the level meant like they're not high enough to qualify for it. They just never know what the level is.
Yeah, but I don't think they would. For omalizumab or for the other one?
For omalizumab.
Everything else was exhausting. That one.
Yeah. What about for somebody who has high blood eosinophils?
Also.
No. Right? So these are your anti-IL-5 medications. And I will write it on the board for you because I'm sure I'm going to butcher the pronunciation.
terms of grading asthma, can you go based on medications and symptoms, or is it purely symptom-based? You know what I mean?
Say that again.
Like, if I want to say it's mild, moderate, or severe, can I either go based on what the patient reports as symptoms or based on what I see on their med rec?
So I would step up, usually you should step up from their med rec. So if they're only on albuterol PRN, and symptom-wise, you're like, oh, they might be moderate to persistent, I would still just do that one step up of going to the inhaled corticosteroid as opposed to jumping like 2 or 3 steps based on their symptoms. Where did I write it? So these are the 2 IL-5. So say somebody is already on kind of maximum therapy. They have done omalizumab. Maybe they don't qualify for the anti-IL-5. What could be kind of a last-ditch intervention that you could do for their asthma?
Do the burning.
The burning, right? So bronchial thermoplasty. So I think with these, they're not going to, I think it's going to be pretty obvious. They're not going to give you bronchothermoplasty with other kind of pulm interventions that might sound similar, but kind of knowing that these are for severe patients with allergic asthma. So some wheezing patterns, right? So kind of paying attention to the wheezing patient on the test and making sure that it's not an asthma mimic, making sure that it's not kind of an asthma plus type syndrome, or that there's anything else that could be exacerbating their asthma that you could intervene on, right? So the first one is a patient who has asthma, who has nasal polyps, they're on ibuprofen, aspirin sensitivity. What would you recommend? Correct. Stop your ibuprofen. What medical therapy could you try to use? Say they need aspirin for their stent or something like that. A leukotriene modifier. Somebody who's wheezing or short of breath in the cold. Exercise induced. How do you manage? Albuterol 15 to 30 before exercise. Patient who has a history of asthma, they're on steroids. Symptoms are coming back after steroids are weaned. They're saying their sputum is brown. You have a CT chest that shows central bronchiectasis, ABPA, right? So central bronchiectasis is a big buzzword for ABPA. How do you treat? If you had to pick one drug for ABPA, it would be steroids, right? This is an allergic condition. So it can be in patients with asthma, it can be in patients with cystic fibrosis. Sometimes you can use antifungals like itraconazole, but really you need to be decreasing their inflammation and their allergy, and you're doing that with steroids. Cough, progressive shortness of breath after returning home from work daily. You might see some opacities on CT chest. Hypersensitivity pneumonitis. You're given a couple of options for therapies. What's the first therapy you pick? Remove the allergen, right? So if your options are stay at this cool job because you love it with some steroids, or get a new job, it's going to be get a new job. Get rid of that pet. A patient who has asthma on Montelukast, steroids get weaned, they're having worsening pulmonary symptoms, maybe they have a foot drop, a rash. The better name or the newer name for Church-Strauss, EGPA. EGPA is what kind of a vasculitis? Did you guys just talk about it in nephro? Small vessel? Possible. A patient from the DR has recurrent cough, wheeze, eosinophils, chest x-ray has kind of these infiltrates. Maybe they migrate those infiltrates. Loeffler's, which is a benign parasitic pneumonia. Loeffler's.
Do you treat that with the antiparasitic?
I don't believe so. I think it's self-limiting. Wheezing, exacerbations don't really respond that great to nebs. They have an inspiratory wheeze. VCD, right? Going to question number 4, right? So this is our patient there. What is your next step in evaluation? All right, laryngoscopy. Asthma patient with cough, wheezing, low-grade fevers. Chest x-ray shows peripheral infiltrates. Sed rate's high. The BAL is positive for EOs. Chronic eosinophilic pneumonia. Why is it not acute eosinophilic pneumonia? Those patients are like ARDS style patients. Very sick, high mortality, very acute. This is somebody who's a bit more chronic, insidious. How do you treat this? Steroids, long-term steroids. So going back to question 2, the preferred drug for the chronic treatment of asthma when symptoms are not controlled by your short-acting beta agonist. Inhaled corticosteroids. What medications should never be used as monotherapy in asthma or a patient with asthma COPD overlap? LABAs. So moving on to COPD. Again, kind of our ladder here is based on the severity, looking at their FEV1. So if somebody is on a short-acting beta agonist only, are we out of papers? Does anybody have extra question papers around?
Yeah, there's one here. That's true.
Right, so when you are making this jump, right, so as opposed to asthma, when you're making the jump from just albuterol to the next drug, which is inhaled corticosteroid, your first jump here is to a bronchodilator, right? So that bronchodilator could be an anticholinergic or a LABA, right? So a big difference here with a risk of increased mortality on the asthma side, so they always ask those questions. What is the most important thing you can have your patients with COPD do? Stop smoking. What therapies for COPD can decrease exacerbations? Roflumilast. Bronchodilators like Spiriva. And Zithro 3 times weekly.
That was number 5.
Say that again? That was a just
Generic.
off the cuff question. A free question. So number 5 is what medication, right, which is a PDE4, phosphodiesterase 4 inhibitor, which we use for patients with chronic bronchitis type, severe COPD, will decrease exacerbations. Roflumilast. Question number 6. When you are prescribing oxygen therapy for patients with COPD, right, they meet criteria, they're resting O2 sats are less than 88%, or any of the other criteria, your goal is 24 hours a day, but what is really the minimum that they should be doing to get that survival benefit? 15. So moving on to our next 2 pages here. So these are our diffuse parenchymal lung diseases. That's not helpful. So these are really organized by kind of associations that you should know, right? So actually let's start with the second page, right? So the associations here is the occupational history, right? So these are the buzzwords for these ones in blue. So somebody's giving you a rock worker, quartz, stone cutting, silicosis, right? You could see these eggshell calcifications like you see here in this picture. See that little egg? See the egg? It's like Easter. You can also get progressive massive fibrosis, and you start seeing kind of fibrotic changes in the apices. They're at increased risk of TB, lung cancer. So if one of these patients has chronic respiratory symptoms and then they develop worsening respiratory symptoms, night sweats, fevers, you need to be thinking of diagnosing their TB on their underlying silicosis. Coal can have the same kind of radiographic appearance to silicosis. It's just the pathology is different visibly on biopsy. What rheum condition is associated with coal workers' pneumoconiosis? RA, we call that Kaplan's with the C. So a patient who is in the shipping industry decades ago and now coming in with kind of dyspnea or chest x-ray changes, you need to think about asbestosis. The most common manifestation that you'll see from asbestosis is benign pleural plaques, right? Like you can see here. You can have pleural effusions. They can be bloody and still be from asbestosis and benign, or they could be bloody because of mesothelioma in the setting of the asbestosis. So the bloody could go either way. So this guy down here is half blue and also half orange. He's blue because he might have a history of being in electronics, aerospace, metal, and dental prostheses. And he's orange, right, because you have this buzzword of kind of granulomas on your biopsy. So what's this guy down here? Borreliosis. So this is your sarcoid mimic. So it will look like hilar lymphadenopathy, but they will give you those exposure history, and they'll give you this buzzword here of this lymphocyte proliferation test. So if you see an abnormal lymphocyte proliferation test, you need to think borreliosis. So then scooting back to our other granulomatous diseases, right? We talked about sarcoid with borreliosis as the mimic. There's 4 different stages of sarcoid, whether it involves just hilar lymphadenopathy, plus or minus lung changes, and then stage 4 is kind of end-stage fibrosis. Treatment for sarcoid is challenging because there's really not a lot of improvement that you get from therapies. So if somebody has really kind of significant organ infiltration, right? So CNS, eye, really progressive lung changes, then you would want to be kind of increasing the immunosuppression. Sarcoid, you need a biopsy, right? Why do you need to confirm your suspicion of sarcoid with biopsy. Why?
Could be cancer.
It could be cancer, right? A lot of other things can cause kind of lymphadenopathy in the hilar region. It could be infectious, TB, it could be lymphomas, it could be germ cell tumors, right? So you need to always biopsy. Tissue is the issue. When are the few exceptions where you do not need to biopsy somebody and you can say, this is sarcoid? Lofgren's, which is what? Erythema nodosum, hyalurolymphadenopathy, ankle arthritis. And then what's the other one? Yes? Right, Herefort's, which is the parotid, uvuloparotid glandular syndrome. So those are the two where you can say, this is sarcoid. I feel comfortable saying this is sarcoid. And at least with Lofgren's, it will resolve and go away. So now we're middle one here, granulomatous disease. This can present acutely, subacutely, chronically, recurrence with exposures. The infiltrates usually are kind of upper mid lungs, we think. Hypersensitivity pneumonitis. So if you did a biopsy, you would see granulomatous changes. Not that you would need to always do biopsies in these patients. So remember, upper to mid lungs, right? Think of it as you're breathing in that allergen and it's rising to the top of your lungs. So if you're seeing imaging where it's really a lot of kind of lower lobe stuff, then I would kind of, maybe rethink this as the diagnosis. Let's go to our smokers up here in pink. So we have smokers and we have cystic lung disease, right? So these two on the side are cystic lung changes, and then this top person is a smoker, middle-aged, with maybe a pneumothorax, cystic bone lesions, diabetes insipidus, Langerhans cell histiocytosis, aka histiocytosis X, aka
Yeah, that's sex.
there's another one, eosinophilic granuloma, right?
I'll trust
Get
you.
on that one.
Alright.
Your therapy for this patient,
Steroids. Not steroids.
it's pink. Why is it in pink? Stop smoking, right? So pretty much all of these pink ones, you're going to be saying stop smoking. So this next one is a middle-aged individual. They might have a smoking history. They have really impressive imaging findings, and usually they're pretty asymptomatic for a long period of time. So you have ground glass changes. You have thickened interlobular septa in polygonal shapes. Crazy paving, right? So instead of giving you the buzzword crazy paving, or on the test, they are going to say this: thickened septa in polygonal shapes. This is PAP, pulmonary alveolar proteinosis. So not just BAL, whole lung lavage in the OR, right? You are taking them to the OR, you're intubating one lung, and you're just flushing liters and liters and liters out of the other lung. Then you switch. Excellent.
So eosinophilic granuloma is used to describe a single lesion, like in a bone or something, but yeah, it's pretty
Gotcha.
interchangeable.
Okay. Active smoker, and they're I won't call that middle-aged anymore, in their younger years. This is reversible and self-limited. You see ground glass opacities in the upper lobes. This is related to their smoking. RBILD, right? So respiratory bronchiolitis, interstitial lung disease. But if it's all spelled out on there and look, that's RBILD. Great, right? You're going to tell this person to stop smoking. Another smoker with opacities now more in the bases, right? This is more upper lobes. This is more bases. You see macrophages filling the alveoli on path, right? We talked about this in lectures before. What is in that alveoli? Because they're smokers.
A dip.
Dip. Dip. Right? Dip is like the tobacco that you chew.
Oh, the actual dip is in the alveoli?
No, but that's how you remember.
There, you're doing it wrong.
Right? So the other ones go to the top because you're smoking it, right?
I'm so lost.
Imagine these patients are doing dip, right? So it's filling their alveoli. So it's in the bases,
Oh, okay.
right?
It's an analogy.
It's an analogy.
It's a mnemonic.
It's not the actual dip in the alveoli.
It's a visualization for
Okay.
learning.
The gravity of the dip is dipping.
Yes. And DIP stands for Desquamative Interstitial Pneumonitis.
I see what you did with the dip.
So which ones do you associate with smoking? DIP, RBILD, histiocytosis X, pulmonary alveolar proteinosis. So our other cystic lung disease usually affects females more often than males, middle-aged. It can happen sporadically or in association with tuberous sclerosis. This is LAM, lymph angiomyomatosis. So those are all of the different cell types that should not be in the lung, that are in the lung, right? In those cells. Lymph, blood vessel, smooth muscle are all in the wrong spot. So these patients can present with spontaneous pneumos, chylous pleural effusions, and you'll see a lot of honeycombing and cystic changes in their lungs. So going back one page. So looking at the bottom here with our autoimmune, right? So they're giving you autoimmune risk factors now in the stem of the question. Maybe sclerodactyly, maybe Raynaud's, joint pain. So you're thinking, is this autoimmune as the cause of their kind of parenchymal lung disease? So this one is kind of ground glass in the bases, maybe some sclerodactyly, SCL70s positive, systemic sclerosis. This next one can really have any sort of manifestation, pleural effusions, bronchiectasis, nodules, usual interstitial pneumonia, bronchiolitis obliterans. What can cause anything in the lung? RA. Proximal muscle weakness, non-specific interstitial pneumonia or organizing pneumonia, positive Jo-1 antibodies. Anti-synthetase syndrome. What cutaneous manifestation goes with anti-synthetase syndrome? Mechanics hands, right? So if you see Jo-1, ILD, you should be thinking anti-synthetase, and they'll give you mechanics hands, which is like just crusty fingers. All right?
We got ready.
And then, what?
No.
And then obviously, your pulmonary vasculitis can cause some ILD, and you'll have other kind of clues with that, maybe hematuria, hemoptysis, ANCA positivity. So if you are seeing NSIP on the path, right, you should think, what sort of etiology? There's more waters back there too, if anybody wants some. On the table. All right. Going up to eosinophilia. Right, so here's a clue. You have somebody with lung pathology and they have eosinophilia. What things should you be thinking of, right? So we already know EGPA. We already know this one. All right, our respiratory symptoms, wheezing, migratory infiltrates, Loeffler's, right? So this is our self-limited parasitic, more Ascaris is self-limited. We have drug-induced causes. And then we have this one, middle-aged, photonegative CHF, eosinophilia. We already said we're giving them long-term steroids. This is our chronic eosinophilic pneumonia. It's not acute because they present how? Very sick, like ARDS, intubated, high mortality. And then what do you see on chest x-ray for chronic eosinophilic pneumonia? Bat wing, right? You see these bat wing. So that is the photonegative infiltrates, right? So photonegative pulmonary edema infiltrates, right? Usually pulmonary edema you see all around the hilum. So if you inverted it, this is what they mean by photonegative pulmonary edema. History of lymphoma treated with chemo and XRT 8 weeks ago. What do you see here? Radiation pneumonitis, and you know it's that because it's localized into a non-anatomic field. So now our green guys are kind of idiopathic etiologies, which the most common one tested is going to be idiopathic pulmonary fibrosis here on the left. So it's usually an older individual, males, clubbing, they'll have Velcro crackles in their lung fields. Usually a lot of these questions focus on prevention of complications, right? So flu shots being up to date, potentially an early lung transplant evaluation, ruling out other causes or etiologies that can be treated. So they'll give you in the STEM kind of autoimmune workups negative, or there's no Raynaud's, and kind of giving you things that lead you towards IPF. They are also going to want you to rule out other causes of dyspnea when they're coming in acutely dyspneic, right? So before you're saying this is an exacerbation of their IPF, you're thinking about, is this a pneumonia on top of their IPF? Is this volume overload on top of their IPF? Is this a PE on top of their IPF? So excluding things that you can actually help, because this you really can't help. So once you get to that stage where you've ruled out anything that you could really help, and the patient is doing very bad with kind of end stage IPF, they're going to want you to pick hospice. So they are going to want you to recognize when they've gotten very bad and have discussions about palliative care over things like mechanical ventilation at that point. So this one is focal areas of consolidation that kind of come and go. They keep getting antibiotics. You might need a lung biopsy to diagnose this. COP, cryptogenic organizing pneumonia, right? So instead of antibiotics, what they need is steroids. So this is acute interstitial pneumonia, which is really kind of on the same spectrum as ARDS. It's a really severe presentation. The imaging and pathology is very similar to ARDS with the diffuse alveolar damage, a high mortality, and you would treat it with steroids. Is this one ham and rich?
Yeah.
So let's go to the pleura. So again, kind of moving along through this a little bit quicker, all right? Kind of things that they commonly test. Knowing when to observe versus do a thoracentesis on a pleural effusion, right? So if somebody has a new effusion, a unilateral effusion, and it's more or a effusion more than 1 centimeter in the setting of a pneumonia, that is when you are going to do a thoracentesis, right? Somebody has bilateral effusions, CHF, nephrotic syndrome, right? Those situations, you would usually try diuresis first and see how that goes. So the thoracentesis, this is normal. This is chylous or milky. So if you saw this, what would you check in the fluid? Triglycerides and
Something else. Lay out.
you could check chylomicrons. This one, bloody, cytology. What are other things you think of with blood?
Asbestos.
Asbestos. I don't know about RA. PE could sometimes be bloody. Trauma, right? Maybe a hemothorax. Usually it wouldn't be this translucent. What's this? Pus. When you see this, they need chest tube and their antibiotics. But this is pus equals chest tube. Lights criteria. How many do you need to say it's an exudate? Just one. How many do you need to say it's a transudate? All of them negative. I guess it's easier just to remember if any one are positive, that is an exudate. I'm trying not to be confusing. So going down the transudate side first, right? So say this is a transudate of effusion. You kind of go back and look. Most commonly it's CHF. It could be a hepatic hydrothorax, nephrotic syndrome. So a lot of different causes. A patient who has a urinary obstruction on the right, status post to urologic procedure, now has a right-sided effusion and the fluid is yellow and smells of ammonia. What do you think? A urinothorax. What do you check on the fluid? Close. A creatinine. You want your fluid to serum, well, I guess you don't want this, but your fluid to serum creatinine would be more than 1. So it's usually on the same side as a kidney that's been obstructed. So it's almost like the urine goes.
Is it coming like from the kidney or from the urine?
I don't know if it's, I don't know if you can determine where there was that disruption. A patient has a history of hepatic hydrothorax on the right, now has fever and worsening dyspnea. The thorax shows straw-colored fluid. It's transudative. The cell count's 800 with 80% PMNs. What is this?
SBE.
SBE,
That implant.
or sometimes it's also called SBP, spontaneous bacterial pleuritis. I think it's been pretty recently renamed because SBE is misleading, right? That it's an empyema and that you would need a chest tube. But why do you not give these patients chest tubes? Right, because they'll never stop draining that fluid. It's a hepatic hydrothorax. You're just going to have that constant fluid. You're never going to get to a point where, hey, it's less than 100 mLs in 24 hours. So you're just going to keep draining them. So it's SBP of the lung. So you treat it with antibiotics. Right, so pay attention that, right, in the transudative nature is also a little bit misleading. So even though it's not exudative, it's still a problem, infection that needs intervention. So say you have an exudate, that means you have a lot more work to do because you need to figure out why this patient has an exudative effusion. Sometimes it's easy to figure that out, and sometimes it takes a little bit more investigation or time to see what happens, right? So we talked about the empyema, right, and knowing when to put in a chest tube. If there's pus, any positive gram stain, low pH, low glucose, high LDH, give them a chest tube and, right, give source control for that abscess is what you're doing. TB is usually lymphocytic, maybe bloody. The adenosine deaminase can give you a clue, so it's helpful if it's usually around 35 or 40. But all of your other stuff like AFB, smears and cultures and all of that are not going to be helpful. So if you're still thinking TB, then your next step is going to be a pleuroscopy, right, with pleural biopsy. For malignancy, you're checking a cytology. It could be a lymphomatous pleural effusion, so checking flow as well on the fluid. Cytology can be negative, still in the setting of a malignant effusion. So this is where if all of your workup's negative and you don't have an answer, sometimes repeating the thora for a second round of cytology is helpful. A chylothorax has elevated triglycerides. You can also see that with malignancy, lymphoma, trauma, LAM. Remember how we talked about LAM having chylous pleural effusions? PEs can really straddle both sides. So a PE can give you a transudative or an exudative pleural effusion. Autoimmune causes, RA can cause anything. Remember that a low glucose can be suggestive of RA. What else? The other thing to point out here is the last one, the CHF post-diuresis exudate. It's somebody who has heart failure and you've diuresed them a lot, and then you tap them. They may meet Light's criteria just off of this one protein measurement. So that's what you would call a CHF post-diuresis effusion, where you're saying technically it's exudative, but there's no other cause, and I feel like this is secondary to kind of the effect of the diuresis. You could check pretty much like a SAG, right, but of the pleural fluid, right, so a SPAG, serum minus pleural albumin gradient, a SPAG. So check a SPAG, and then if it's over 1.2 as opposed to the 1.1 for portal hypertension, that says transudate. So if you do all of this stuff, and you're like, I don't, cytology's negative, the fluid's really just yellow and straw color, nothing grew, and I really have no reason for this pleural effusion. Where do I go next, right? I feel like it's a common place that we get trapped in a patient assessment. You should do imaging, right? So do a repeat CT of the chest. After having that fluid out, sometimes a mass or a pleural abnormality may become more evident. You can do repeat testing, right? So do a thora again, send down more volume for cytology. Maybe investigate TB if you didn't send an ADA before. But if all of that is really non-revealing, then you're kind of left with, I'm just going to watch and see if it recurs. And if it recurs, then I'll do further testing. Or if you really feel like the patient is pretty sick or already recurring, or it's something is serious going on, then you can do the thoracoscopy. Right, to go in there, look at the pleura, take biopsies, and see if there's any pleural abnormalities driving the effusion. So pneumothorax, we're just going to breeze through these and talk about the treatments over here to fill in on your sheet. So who gets an emergent needle thoracostomy? A tension pneumo, right? So these are all potentially different types of pneumos over here and how the treatment differs between them. Which pneumos can you just observe? How small?
10%.
So like 2 centimeters, less than 2 centimeters of air and asymptomatic you observe. What do you do while you're observing? Oxygen, right? Who would you pleurodese? So if somebody's had recurrent episodes,
To do a secondary cause.
so if somebody has secondary, right, a secondary pneumo, right, so they have COPD with bolus disease, they have their first pneumo, and you're like, I am suspicious that you could get another pneumo or have issues, or I wouldn't be able to take out this chest tube. That's when you would pleurodese with their first incident, right? Otherwise, with the primary, you would give them a pass, right, on the first one. Who gets a chest tube? Right, so greater than 3 centimeter secondary pneumos. Who can you just send to radiology and they aspirate the air? Yeah, sometimes you can do it with primary pneumos. Just suck out the air. High flow supplemental oxygen. Everyone. High flow for all. And you just have to make sure you talk with nursing staff. Thoracoscopy. So usually, right, when would you go in there and look around? Right, so if it is, so if you're worried about a bronchopulmonary fistula, if you have somebody who has a second occurrence and they're one of these people, right, so is there any pleural abnormalities to go in and see? That's when you would consider that. Remember, no air travel until it's resolved. And what other fun things should they not do in their life? Scuba diving. Sorry, Jake. He's tall. He better not get an pneumo. Our PE page. So again, in the workup, all of these things, your exam, the EKG, ABG, chest x-ray, these could all be suggestive of a, am I not going in order? Yeah. Sorry. It's like, why is there so much flipping? So EKG, ABG, chest x-rays may give you some clues, but you are not going to be diagnosing or treating for PE off of those. What chest x-ray finding do you see here? Hampton's hump, which is a wedge-shaped opacity representing an infarct. What do you see here?
Westermark.
Westermark sign. Yes, in the circle. So Westermarck sign is a relative oligemia, right, or decreased visibility of blood vessels, right? So if you see here, we see some, right, tracking of these vessels up, but here it's darker. Again, fun things to look for, but it's really not going to be the end of your investigation if you see those. So you are going to be assessing your pretest probability. Does everybody know about the calculators on the boards?
Where are these?
What? Okay, let me show you.
Is it like a New World too? Yeah. I don't know what the calculator looks like.
I'll show you the calculator because it's amazing.
There's a link to the 60.
Your answer to this is to be seen.
It'd be nice to know, but we don't need to know.
I know. That counts.
What website is that?
Open my calculator. There. Oh, I don't want that calculator. I want. So here.
Has anyone found this on Google?
Can't they just
So-
get MD cap? Like, that'd be so much easier.
That would be cool.
Why can't they just let us use their cell phone?
So these are all of the calculators that are already given to you on the test.
Is it also interpreted for you?
Yeah.
They, right, so let's put in. So let's see.
Oh, no way.
Wait, it tells you your recommendations?
You
Right.
just know to use
What's
it?
page 2 show? Because that's only like 6.
Let's see it.
Yeah, page 2.
Are those the only calculators that are up there?
So I feel like there's more.
You need to give me like 2 screens for this test.
So I'm pretty sure, pretty sure Wells was on there, which is why I wanted to show to you. Yeah, I just clicked page 2 and it just showed up this.
I could add us a pad too. I'll see if I can find a list because I don't think that tutorial has them all. Because I feel like stool osmolar gap was also on there at least last year.
What's a basic caliper? Let's look at that.
That's for your EKG.
They give you a caliper on it?
Cool.
I thought it was another one of these links.
Okay. So I believe this score is already given to you in your calculator on the test, but I will double check and see if I can find a full list of calculators that are on the exam. But they are going to want you to be able to, right, plug in these things in their calculator for well score, and then you assess what to do with the number, right? So they would tell you perhaps low or intermediate or high, and then you need to know what to do next. So if somebody has a low pretest probability, your next step is going to be a D-dimer, and if that's negative, you're done, right? If somebody has intermediate to high risk, right, you have really high clinical suspicion, so your first step is going to be start treating them, right? That way they're not coding in the CT scanner or anything like that. And then imaging. The preferred imaging choice is going to be your CTA. And when are you going to be doing VQ scan?
Prayers.
So different, I don't feel like they'll ask you that because depending on the guideline you look at, whether it's from like the radiology people, the OB people, it will all tell you different things. The last I was aware of, CTA is going to be your gold standard for pregnancy.
Obviously, if you can diagnose the PE in other ways, right? Like if you do a lower extremity Doppler and they have a clot, great. But actual radiation dosage is higher with the VQ. So initially they were saying that, oh, well, CTA has iodine, and perhaps the iodine will affect the baby's thyroid, but no, it doesn't. There's a lot of controversy around that, and I feel like certain things still, like MixApp and MedStudy, have differing things that they teach that I don't think they would ask it. So you could choose ultrasound first, because if you can get your diagnosis of DVT, you would just start therapy, right? You wouldn't need to do any other testing acutely at that moment. If they're unstable, that's one thing, but usually they're gonna give you somebody, and you could potentially diagnose them with a Doppler. But if the Doppler's negative and you want to go to a higher level test, I would say that there's more evidence for CTA, with the caveat that it's controversial depending on which source you look at. When do you do VQ? Renal failure.
And you need to get chest X-ray.
A true contrast allergy. And, right, maybe not in the acute setting, but if you have somebody that you're worried about chronic PEs, a VQ is going to be your test of choice over the CTA. So you have your diagnosis of pulmonary embolism. How do you define if it's massive, submassive, or low risk?
I go with final.
Excellent, right? So you're not basing that off of the CT, right? Showing this huge saddle PE. Oh, that's massive, a massive PE. May be true, but that's not how you are going to be defining it, right? So you are defining it based on your clinical exam. So if they have hemodynamic instability, that is a massive PE.
And you're talking specifically about hypotension, right? Not talking.
Persistent hypotension. Submassive is RV dysfunction on echo and elevated troponin or BNP are clues towards a submassive. Do the vast majority of people need to be hospitalized for PE? No.
Yes.
At the VA always.
That should be your next core project. Using the PE severity index
To like tell them.
to tell them and strategize who can go home.
This is maybe a dumb question, but can you give TPA in front of the
I am not sure. Where's my rapid Googler?
I'm not that rapid. I take my time, but I'll look it up.
Like a relative? Yeah. I mean, I would say I would say you're just between two things, right? If you're not going to be doing thrombolytics, right, then you would be sending her for like thrombectomy and sucking it out if it's that massive. I mean, that question is, could you just pop the baby out in 10 minutes? Yeah. Right?
Use with caution.
Use with caution. So be very careful.
Increased risk of bleeding. Surprisingly.
So let's talk about some special, right? There's a lot of different options that you have for anticoagulation, and they are going to test to see if you know which ones are best in which situation. So looking at somebody who possibly needs thrombolytics, which option over here would you pick? Right, so somebody has a massive PE. Somebody has a massive PE, and you're like,
I see you.
or they have a submassive PE. What are you? Let's say submassive. They have a submassive PE, and you're like, this person's making me really nervous. I might have to pull that trigger soon. If they get worse, what anticoagulation would you pick? Heparin, right? So you're going to be picking Which heparin? B or I? I, right? Heparin weight-based protocol. Right, so you're picking that one because you could stop it in the setting of needing to do thrombolytics or other interventions because it's quick on, quick off.
Yep.
Somebody has malignancy, E, right, low molecular weight heparin. I don't think it will be on the boards yet for NOACs. History of a GI bleed. So for this, I would say, give me the one that you would not pick. Which one has the higher risk long term, right, for their chronic therapy of GI bleeding? Dabigatran, Pradaxa. It lowers the pH in the stomach, so out of all of the NOACs, it has the highest risk of GI bleeding. Renal disease.
So you said the biggest brand is the worst one. Is the worst one.
Yes.
So the answer is don't give.
Dabigatran is the worst one.
For GI bleeding.
Apixaban's the best one.
Apixaban is the best.
Don't get.
I didn't remember that.
You can give Panaxa.
Oh, because why not use Apixaban for?
For everybody, right?
It's a-
Apixaban is the best.
Yeah.
History or renal, somebody has renal disease. So, acutely, what are you giving them? Heparin to warfarin or potentially apixaban. Renally dosed, and it was even studied in dialysis patients, although I don't think that will be fully launched on your test. Somebody has coagulopathy from liver disease. Their INR is 2.3. Do they need anticoagulation?
Yes.
Yes. What do you pick? Low molecular weight heparin, right? Obviously, you're not going to be doing warfarin since you don't have a what's going to be your goal. What about HIT? Argatroban. Not FDA approved yet. Fonda. Pregnancy, anticoagulation of choice. Low molecular weight heparin.
If they have
Unless
like
it's
a
mechanical.
mechanical valve,
It's warfarin. If it's a mitral, it's warfarin.
But acutely, right? In the setting of an acute PE, right? Lovenox. And for valves, you have a period of time of like second trimester where you can do warfarin, right? Because it's teratogenic. And then you also want to stay away from it during delivery. Second trimester, you could do warfarin. Unstable with unresponsive hypotension. Thrombolytics. Which ones have once daily dosing? Right, so obviously Coumadin and then Xarelto. Somebody who cannot take anticoagulation. IVC filter. Who else do you put an IVC filter in? Really? Nobody, right? So if you can give them anticoagulation and you are giving them anticoagulation, you should not be really putting in a filter.
You should not.
Filters should be put in as a temporary thing, but as soon as you are able to start anticoagulation, their filter should be removed.
So never on the test is there a time when you should be putting in a filter if you're also giving them anticoagulation. I feel like sometimes that's done a little bit different here, where like when IR goes in and does their thrombolytics, they also throw in a filter at the same time as prophy. But if you can give anticoagulation, you do not need to be inserting a filter. Duration of anticoagulation. So a first provoked, yes.
Which one is the poor compliance?
Oh,
It's gonna be a controversy.
did I skip?
Yeah.
Oh, well,
Like a once daily.
so that depends on the situation. I don't think there's a good answer for that one.
Like a no way.
If you are worried about their
Filter.
ability to, if they would have challenges with complying with appointments
Usually just once, they try like a once a day,
and things like that,
hopefully.
then you could try like a NOAC. If you're worried about their compliance with actually taking the pills, the NOACs are hard because you don't have a way to measure their compliance if they're having kind of recurrent events. Whereas with Coumadin, you could say, yes, you are therapeutic or no. So there's not really a good answer for that.
It's an Oller.
And then obesity. So obesity, obviously warfarin, because you can titrate to the INR. Fonda has a 10 milligram dose if you're over 70K. Lovenox is helpful, but there's really a limit on weight in terms of the max dose you can do. Somebody has a recurrent clot on Coumadin or on a NOAC. It's a freebie. So somebody comes in, they're on their NOAC or they're on Coumadin, and they now have a clot. What is usually your go-to to put them on?
Check their
Well, you
compliance.
check first, like is the INR therapeutic?
Say they're therapeutic.
Are they taking that,
They say they're taking it. Lovenox. At least temporarily, as you try to reassess maybe why it happened.
What if they come with that on Lovenox?
Keep the Lovenox.
Oh, keep Lovenox?
Keep the Lovenox, but then you can check 10A levels on it to confirm.
Smart.
Reversal agents. Right, so this is number 7 on the bonus sheet. Reversal agents for patients on anticoagulation who are having life-threatening bleeding. So for warfarin, vitamin K plus, more importantly,
50.
no,
Oh, just kidding.
that's the trap. The trap is FFP, K-Centra.
So they don't give it, like
They
at the
won't give
VA?
it at the VA.
We had a Cal call going, this person's gonna die if you don't approve this, and they go, that's fine.
Oh,
And then
I
they go,
found
well,
it.
document that, will you document that in a note? And he goes, you will.
Surgery
Okay, so I'll have
actually
to do
used it
vitamin.
incorrectly and they
I'll do
used it on the
FFP.
NOACs. What? The pulse elevated
Oh, you're
INRs. They do it all the time. They're like, we do this all the time for surgery. I'm like, it doesn't make it right. Like,
K-Centra is 4-factor complex concentrate. Yeah.
Is K-Centra a brand name?
K-Centra is the brand name.
What's the real, like the generic?
4-factor PCC, protein complex concentrate. You get it quicker, right? You call pharmacy, ooh, here you go. Whereas FFP, you have to type the patient, you have to prepare the blood products, you have to thaw the FFP, you're giving them volume, and you're giving them higher risk for transfusion reactions, etc. So standard of care is the PCC, not FFP. And I don't know about the VA, but you should be getting that here.
yeah, I'll just not call the right people. Listen.
Oh, lovely.
So what?
Maybe that's why they don't give it anymore. How do you reverse dabigatran? What is Praxbind?
Idarcruzumab,
Spell it.
IDRCUMAB.
This is prac spine, right? They're not going to give you, probably not going to give you prac spine on the test. They're going to give you, I should have called it Daxabind. That'd be cuter. Like Digibind, Daxabind.
I know, because all of the medications, the names make sense, you know?
Right. What about Rivaroxaban? Adnexa alpha.
I don't think we have that here yet. We do have
Probably. Net. Duration of therapy. If somebody has their first provoked clot, how long do they take therapy for? 3 months.
Go back on the, go back to your.
Right here. First clot provoked. 3 months. Second provoked clot. 3 months minimum plus discussion. Unprovoked clot. What's the minimum?
3 months.
3 months.
Then discuss.
Then discuss with ideally, right? Indefinite. There's some studies out there about perhaps checking D-dimer to help guide that discussion and look at risk. Somebody who has a clot and cancer until the cancer is treated and gone.
Do we not do lifelong for anyone anymore? Or is that the discussion?
That's the discussion, right? So minimum is 3 months, ideally lifelong because of the risk of re-clot for somebody who is unprovoked. But it involves a discussion with the patient. Upper extremity DVT. Subclavian, IJ.
3 months.
3 months. What about basilic or cephalic? Right? Those are not deep veins. Isolated calf thrombosis. It is not a deep vein. So you could do no anticoagulation and perhaps another ultrasound and follow up. A superficial venous thrombosis. What does it depend on? It is 6 centimeters and it is 3 centimeters from the femoral vein.
Then you need.
When? How long?
I have very specific answers. 45 days.
45 days.
Wait, can you repeat the criteria again? 6
So
centimeters?
usually if it is within 5 centimeters or closer to the junction of the femoral vein.
What about your arms?
I don't know if there's any criteria with that. It's just warm compresses. So if this is a long segment, if this is a proximal superficial venous thrombosis, right, getting really close to the femoral vein, the 45 days initially was with Fonda, 2.5 milligrams. So it was with the prophy dose of Fonda. Then there was the, I want to say the surprise trial, where they compared Xarelto to the Fonda 2.5, and they were pretty equivalent. So you could also do Xarelto for 45 days. Surprise! So some fun little snippets here. 2 days ago, long bone fracture. Now with hypoxia, infiltrates, petechiae in the axilla. Fat emboli. How do you treat it? Supportive care. Plus or minus, controversial. I don't think they would ask that. Acute upper extremity DVT in a young athletic person. Consider this, right? It's a pitcher. Paget Schroeder. or effort-induced thrombosis.
You treat that?
Yes. Um,
Is that like an impingement syndrome?
mhm.
It's like
From micro trauma, from like repetitive use.
yeah.
So you also want to rule out like a thoracic outlet from it or causing it. This similar, but in the leg, is usually on the left side. May Thurner. And why does that happen?
Like anatomical, like leaks.
Anatomically, right. So it's where the left, no, aorta's on the left. So it's where the iliac, right, crosses over the left
I have
vein.
compression of the right iliac.
It's like this.
Right iliac artery
This is the.
overlies the left. Right? What? Whoa, yes.
That's the main.
So the left vein, right, by the right artery, right? Because the aorta comes off like this. Aorta's on left. So the right iliac that's crossing over to the other side crosses over the left iliac that's chilling there. Right?
These are my veins.
Sure.
Left, the left vein by the right artery. You look confused.
No, I was thinking of that song, it's like Left Foot, Left Stop or something.
Right, because if your aorta is coming on this side, and your IVC is on this side, right, so we know that. Aorta is coming from the heart, so here. So this artery has to cross over to get to this leg, right? It crosses this, the left leg
It's compression of the
vein.
right iliac artery. It's the left, that's the left that has.
That's getting, this is right, it's complete.
Yeah, so with her left leg, because that's where it happens.
Yeah, that's what I'm saying. You gotta keep saying that, right? Because I'm like, it is.
A patient codes. Right before the code, she had her IJ removed. What happened? Air emboli. How do you decrease the risk of air emboli?
Delver Valsalva.
Guys have this
Ooh.
We're
So,
pulling it out.
while they're setting up, let's keep going. So, pulmonary hypertension. So, pulmonary hypertension, right, being mindful of the symptoms and signs on the physical exam. Your screening test is going to be an echo. And whenever you see, right, elevated pulmonary pressures, you want to think, why do they have this? Which class of pulmonary hypertension is this, right? And if you remember the little fun mnemonic, 1 is kind of at the top of this. It's like a 1 for primary pulmonary, or like an I for idiopathic. 2, right, makes your cardiac causes. The 3 makes your pulmonary causes. The 4 is the little PE coming in, and then the 5, I don't have anything for. So do all of these people with all kind of classes of pulmonary hypertension need a right heart cath?
No.
No. Who should be getting a right heart cath?
Type 1.
Primary pulmonary, so class 1, right? So the other workup you need to think of is looking at your causes, right? Do they have COPD and you want to do PFTs? Or do they have symptoms of OSA on the stem of the question and you need to do a sleep study? Do they have risk factors for clot and you want to do a VQ looking for class 4? Do they have autoimmune symptoms and you want to be looking for ILD? So you're trying to figure out the cause of the pulmonary hypertension. And really the right heart cath is for class 1 or type 1, group 1 pulmonary hypertension, right? You are using it to
determine severity, and to also determine if they are a responder for which meds? Calcium channel blockers. So when they give you a young lady who on echo has a, estimated pulmonary pressures in the 60s, and they have no other risk factors, and you're thinking this is primary pulmonary hypertension, and you take them to right heart cath and they tell you they do not respond to nitric oxide challenge, they are telling you which class of medications you are going to be not useful for them. Calcium channel blockers, right? So you're going to be bypassing that class of medications, right? They respond, yes, cool, give them a calcium channel blocker. If they don't, skip it. They are not going to ask you to pick one of these therapies over another, right? It's very complex. You're going to be starting usually with monotherapy and kind of adding on as you go down the line. I would say the only time that they would maybe say pick a therapy is if somebody is very severe, very symptomatic, and they're going to have you say, this is a pretty horrible, let's start with the IV therapy. They're going to want you to do adjunctive therapy. If they're volume overloaded, give them diuretics, give them oxygen, anticoagulation, counsel them on avoidance of pregnancy. This is one of the few indications where if a patient gets pregnant, they're asked to terminate the pregnancy. Yeah.
What does ETRA stand for?
Yes. Endothelin receptor. And what's the T? Endothelin. So for group 2, right, so this is somebody whose pulmonary hypertension is from their left-sided heart failure. So again, you're not doing a right heart cath. You have evidence of their heart failure on exam. You're going to be just diuresing them and controlling their blood pressure. If somebody has COPD, OSA, ILD, you're going to be optimizing those therapies. You're going to be seeing if they are hypoxic with their COPD and needing oxygen therapy. So group 4, we talked about diagnosing with the VQ scan. So group 4 also gets anticoagulation, like group 1, lifelong. This would be an indication also to do pulmonary angio, looking for if they are a surgical candidate, which only half of them usually are. We're going to skip the sleep and altitude page. So respiratory failure, they're going to want you to know when to intubate a patient, right? So when to avoid non-invasive ventilation. So if somebody's coming in, they're vomiting blood, they're confused, they need to be intubated for airway protection. It's not like you're going to put a BiPAP on them while they're sitting there vomiting blood. If somebody's had recent facial trauma or surgery, like a transfenoidal surgery for a pituitary resection, you're not going to be wanting to put on a BiPAP mask on them, right? You're going to cause pneumocephalus. So you're just going to intubate them. So management strategies. So what are your management strategies for ARDS? Tidal volume is 6 mLs per kilogram of ideal body weight. Because of that low tidal volume, you are allowing for permissive hypercapnia. How do you target the oxygenation? FiO2, how do you get your FiO2 down, right? Because we want to protect the lung. So you're going to be using your PEEP to get the FiO2 down and to oxygenate them. A patient with COPD or asthma who has a high, say 50 PCO2 on a repeat ABG, they're now acidotic. What do you think of?
Fatigue.
Right? You're worried about impending fatigue, right? If somebody is coming in, you're starting therapies, and their ABG now shows a rising PCO2, you're worried about impending respiratory failure. The other one is here, right? To think about with COPD and asthma, right? Air trapping or auto PEEP. So somebody that's on the vent with asthma, and now they have shock, hypoxia. What do you think about? Breath stacking, right? So you look at the vent and see if they have breath stacking, where they are kind of starting their next breath before the other one finished. And how do you manage auto PEEP? Right? Hook them off the vent and bag them for a while. I think we have a couple of questions left we can go through. So if somebody has symptoms and risk factors for OSA, right? They'll give you they're sleepy, they're falling asleep in the car, their neck circumference is 20.
17.
What is your next step? That's my trap.
Sleep studies.
Sleep study. Because I've had questions before with like they have a very high pretest probability and you just go space.
Nope.
You gotta stop saying.
Even inpatient, you just elevate.
So you still need, right, gold standard for diagnosis is your sleep study on the test, right? It'll say polysomnography. You have in lab and you have at home sleep study. Who does not get at home sleep study? So if you are worried about central sleep apnea, right? So patients with neurologic issues, heart failure.
If they don't have many risk factors.
If they
don't have many risk
then you
factors,
would go
inpatient.
home. Simple patients can get it at home, right? So anybody who has risk factors for central sleep apnea, and anybody who has, we're on this thing. That's why I'm not on the central sleep apnea.
Chronic CO2 retention.
And if you are worried that somebody might need BiPAP, right? So if somebody has neuromuscular disorders, ALS, anything like that, and you are ordering a sleep study, you want it in lab. How do you differentiate? So this is number 10. How do you differentiate central sleep apnea from obstructive sleep apnea during the sleep study? So you can see Shane Stokes breathing with central sleep apnea, but what physically during the sleep study that you're testing?
Obstruction, there's just a pause.
Yes, right? So the effort.
Right.
So you have your chest wall sensors, and with obstructive sleep apnea, right, you have your periods of apnea, no oxygenation, but they have that respiratory effort still. They're trying to breathe, right, but their airway's obstructed. Central sleep apnea, the problem's up here, so they have no chest wall movement leading to the apnea. A patient with ARDS on low tidal volume, FiO2 is 100%, PEEP of 5. Their pH is 7.3, PCO2 is 50, PaO2 is 54. What do you adjust next? Increase PEEP, right? You want to work on the oxygenation, and you're okay with the respiratory acidosis. It's permissive.
Did we skip 9?
Oh yeah, alternative treatments for OSA in patients intolerant of PAP. Dental mouth devices, surgery, UPP, P. There is a thing called Inspire that's a weird pacing thing. Number 12, what interventions have been shown to decrease mortality in sepsis?
Bundles.
Sadly, protocols, no. Early antibiotics within an hour. Prone position. Oh, you're right, that's for ARDS. I'm jumping things here.
Okay, I'll
So antibiotics within an hour. And
Large volume.
30 mg per kg.
30 mg per kg fluids, yep. And source control. First line pressor and septic shock. Yes, norepi. Good. So I will let you guys grab food from the back. And then we have folks here from Munoz and Munoz that want to talk to you a little bit while you eat your lunch.